This video will discuss a CHROME surgery where the maxillary implant torque was very low and the doctor could not deliver the case. The case had 6 implants and 4 of the implants did not get torque. In fact, one of the implants was so low that it came out the number 8 position, but number 9, number 3, and number 12 were all in very low torque. So the doctor just picked up the 2. And this is critical that the doctor picked up the 2 because otherwise it's a floating situation down the road or some other method of delivering a prosthetic. But if you index at least 2, then we can go back to the mouth in a few months, several months, and then just pick up the subsequent temp cylinders. And that's what we're going to show in this case. This case is a little unique because one of the implants moved, and this is also a C2F situation as opposed to this prosthetic you see here. Being a take-home prosthetic, in which case you would just pick up the remaining temp cylinders, finish, deliver. In this case, it's a C2F, so we're fortunate to be able to do an extraoral conversion and put the holes in the right place. As you'll see, that was very necessary because of the drift of the number 10 site. So let's go through the process. The process is try in the prosthetic. Let's make sure that it still fits with the 2 temp cylinders. You could check the bite. We did. It was just dead on. This was a double arch originally, and so just kind of checking things out. And then we will take the prosthetic back out. Doctor made a crestal incision and added the remaining implant abutments. Unfortunately, upon tightening this one down and then removing it, we were going to change the angle because this is the implant that really drifted distally as the doctor was sizing up. So this implant came out, still had 4, and that's what we went forward with. So abutments are in, torque them down. This is a Nobel system, so just of course follow the Nobel torquing parameters. All right, so they're in. And then the temp cylinders, and then this is a kind of routine where we pick up rapid appliance. In this case, because this implant drifted so far, we ended up having to open up the other carrier guide post hole. So we opened this up to pick up the implant. It's actually kind of nice. It drifted this way. So now with it open, we'll take it back to the mouth and seat the prosthetic so that we can lute the temp copings in these sites. Now this site here, there was a large opening, so it was easy to use a big tip and pick it up. On the site where we had to open up the carrier guide hole, there was very little room around the temp cylinder. So we used a micro tip. This is one of these micro tip for composites or for endo. Very, very handy because you can really fit it into some tight spaces. All right, okay, so we picked this one up and cured it, let it sit, cured it with a light, and then because this is a C2F, this came out and the doctor sutured and then just waited for us to do the conversion back in the lab. So let's go through the C2F process on this case because this one's a little bit unique. 4 implants, this one drifted, so we picked it up in that site. And if you are familiar with C2F, you'll know that the prosthetic has to sit on both of these carrier guide nubs in order to get oriented, but we don't have that option here. So what we did was we just cut off this nub. We left it as a post, so it's still holding it in position, holding it vertically, but the whole prosthetic could still rotate. So what we did was we had to fit it, a little extra material down here, so we just kept adjusting it until it was down. See here. And then with C2F, you know how we drill the holes through the take-home prosthetic. In order to keep the prosthetic oriented to the model, we drilled and we left the drill in. And then that kept it tight, just like a post, onto the model. So we left this one in and we drilled the other hole. Pretty nice. So now instead of having these, large holes and a mess everywhere, we have some nice small holes. So we drilled them all through, and then you can see here how we picked that one up. Opened up the holes a little bit just to make these rods go in a little bit easier. Sometimes these rods are the tolerance of them is the exact same as the drill. So sometimes it'll BB burr, or even the drill will just ream this hole out a little bit so that they fit in better. It's a little tip. We cured. All right, finished. And here we have the prosthetic ready to deliver. I'm not going to go through the whole C2F process. We have plenty of videos on that. Adding the copings and doing a little bit of adjusting, that kind of thing, to make them fit just right. The patient had a little bit of gap, so we just backfilled it with some stellar. It's not a perfect job, but it'll help the patient with some speech. And then we were ready to deliver. Now, one thing we always do is we take an OEM screw and we drop it down in here to make sure we can see threads. And if you don't see threads, then take a drill and ream out the holes. This is the perfect size to ream out any material that would have flowed in from the injection port. Sometimes you get a little bit above the coping, so use the drill to clean that out. Overall, this was a really nice turnover of a case, really nice outcome. And I guess you could ask yourself, which one would you want to deliver? I think I would choose the C2F every time. Small hole technology. Patient bit down, literally no adjustment. This was an oral surgery's office, an oral surgeon, Dr. Eric Fried, who does these surgeries frequently, does just a glorious job. And then the patient goes back and sees the restoring doctor for any minor equilibration. They all work pretty closely, proximity-wise. But the patient had no adjustment, and the case was delivered. So that is a delayed delivery of an indexed prosthetic.